the condition becomes stable, but stable is only under the high inotropic. So we ship the patient transfer to our hospital in 2020. As I remember, is the 2021 January, and when he come to our hospital, the patient was collapsed and he was put on ECMO. In that time, we were forced to put on the L bed for the patient. So in that condition, we put on the Harmony 3 and under the ECMO support. He removed the ECMO immediately in the operation room, but unfortunately, the patient collapsed in the night time, and we forced to push the patient go to operation room the second morning, and he was put on the R bed. He suffered from a lot of the complication after the biological assist device, and finally removed the R bed in 2021 October 12th, and he was discharged. Do you know the condition for this patient? Bilirubin rise up to the 40. 47, I think is the most the highest number. So after the procedure, he was discharged to the hospital, and he was independent under the Harmony 3 support. So this when the patient was put on the bed, I believe this data is the patient under the evaluation of the heart transplantation. For the heart transplantation, we usually, please remember the cast data. This data is before the Harmony 3. This data is under the dopamine support, 4.5 microcolumn per kilo per minute. Usually, we do the procedure of the catheterization. We will see what's the pulmonary artery pressure, what's the weight. So when we see this data, okay, could this be?
Suami bukan SMA 61 kan? Kenapa? Suami SMA.
Could this patient PVR? How is the PVR? The data shows here. This is the second catheterization. The first catheterization, when we perform the catheterization, we show the PAP was also 77, and the PVR approached 6 unit. In that condition, we will have some discuss about is this severe pulmonary hypertension is contraindicated for the heart transplantation, or it just the high pulmonary artery pressure is related to the poor LV function. So the way we do is put on the inotropic. That's why you can see we give the dopamine, or sometimes we give the dobutamine. We usually up to the 10 microcolumn kilo per minute. In that condition, we will recalculate the PVR. When the PVR is going down, it means this pulmonary hypertension is reactive. Is not contraindicated for heart transplantation. That's why we do this catheterization. Say, okay, this PVR is 2.3 unit. It means we can perform the heart transplantation for this group of patients. And so, in that condition, we put on the Harmony 3 in 21 May 27. We recast again. You see, the CVP dropped down and the PAP dropped as well. You can see the TT shows severe, moderate to severe TR. So we do the tricuspidoplasty as well as the RBED in the next day. So We have encountered some mistake in that condition. We performed the harmless 3 implantation in May 26, but the patient put on the RVAD in May 28. It means there's some delay. Actually, in the operation room, during the harmless implantation, we get off the operating theater under a very high inotropic. So in that condition, we should put on the RVAD immediately, not delay 2 days later. So you can see this data. We put on the RVAD and try to win off the RVAD. It takes about 3 months. So the condition is very, very poor in that way. Okay, so after that, he's independent. Independent and under harmony. This is the pre-operation, pre-heart transplantation status. He has a good hemoglobin, and the CRP is low, and the bilirubin also decreased. Unless, except the creatine level is still a little high. So this is the echo we have now, and this is the pre-heart transplantation CT for the patient. You can see here, there's very clear say there are some very near the sternal. Usually for this group of patients, we usually delay sternal closure for days. Then we will clean all the blood clot and cover the Gore-Tex membrane for the next entry. Okay, now the patient come to hospital because we have a donor coming up. He is 35 years male. He's 97 kilogram. The reason why we should choose a much weighter, much high body weight, because you can see the patient has the relative high pulmonary artery pressure, even under the harmless 3. Even under the harmless 3, the pulmonary artery pressure is still relatively high. So that's why we would like to pick a big heart for the donor, for recipient. This is another important issue. If the body weight mismatch is over or under, you may have some possibility of the graft failure, especially for the body weight is less than the recipient. It means the donor body weight is more than the recipient. So for the pediatric group, we would like to pick a big heart for the small recipient. Since the pediatric group, they may combine some mix of the pulmonary hypertension. Okay, let's go on. The donor shows the heart echo EF is good, the LV EDD is good, and there are no hepatitis C. We routine to check everything for cross-match, including the T cell, B cell, and cross-match. So it's dependent on the central. Okay. Euroscope usually is not planned to estimate the patient under heart transplantation because it's quite different story. But in my hospital, we would like to have an analysis of the Euroscope. So it's our routine, even in the heart transplantation group. But you must know, Euroscope is not suitable for the heart transplantation group. Okay. So the patient received the heart transplantation under the blood pressure and the liver fat, and the cross-count time is 202 minutes. The hospital, the donor hospital, is about to take about 1 hour traveling to my hospital. But the issue, we take a lot of time to do the procedure, is due to the fibrosis or the adhesion. This patient take a lot of time to take out the harmony, and there are some adhesion at the left upper lung adhesion. So you have coagulopathy, a lot of bleeding from that area. So the patient or try to win, we found the ventricular contractility is very poor and very high CVP. So it's very unstable hemodynamic. So in that condition, we may think it's due to a harvest issue, it may due to the donor issue, or it may due to the recipient issue. So when we see the primary graft failure, we must consider which issue may be the important one. Usually, it's difficult to differentiate which one is the key. So, as I say, from this case, we must think. So, any kind of the reason will lead to the primary graft failure. We will think the donor side, the recipient side, or the harvest problem. So, the best thing is to prevent the primary graft failure is to be prevention. So when the prevention is happen before the procedure. So once you encounter this kind of the hemodynamic stable, we must put on the ECMO for a while. And so the sternum will stay approximate. And this is the data we have. The pressure is acceptable and the PAP is low, but you know the condition is under full flow of the ECMO, 1.4 liter. So after the procedure, you can see here, the blood pressure is here, the PAP is not so high. Okay, when we go up of the bypass, the LV function and the RV function become very poor under the T, even under the high inotropic. Under the high inotropic, you can see here the pressure is not so good. So after that, we put on the ECMO, the pressure will become better. So in that condition, we will just put on the ECMO. And we come back to the ICU under the relative high inotropic, dopamine 5, phosphine 0.05, isopropylenol, and inotropic equivalent around 60, and keep the good hemodynamic, but also in the good ECMO flow, around 2 liters. So the patient will suffer from a lot of bleeding. So we repeat the procedure of the re-entry and clean the blood clot. Okay, you can see here, like about 5, and in the day, the condition become more stable. So if you do the reoperation cases for the heart transplantation, you may encounter some of the bleeding after the heart transplantation. Okay, this is the day 1. You can see there are some pack in the heart, and wait for a while, and you can see here the next day the lung, there are some collapse over the left upper pulmonary area. Okay, the chest TTL amount in the first day is 4,000, and the urine output is not good. Then we must reopen it because of the tamponade. Next day is also almost the same, but the lactate has become more and more stable. Even we clear up the hematoma, there are a lot of the blood clot accumulate after we reopen the case. Okay, we reopen again. So in 3 days, we reopen twice or 3 times. And the third time, we reopen again, and also the lactate become more and more better. And we recheck everything. We suspect, we do the CT. When we see there's something wrong after the transplantation, the myocardial did recovery, we will repeat, do the echo and do the CT. The CT shows here, they are suspect, they are hypoperfusion of the septal area. So the patient received reconsideration after the CT to rule out any coronary artery disease. Any coronary artery disease. So, but when we do the coronary artery disease, there are no stenosis, no blood clot in the coronary artery. So it means it may be artifact. So we leave it alone. The reason why we do this procedure, we have encountered one case, I think 5 years ago. The patient also received heart transplantation and the LV dysfunction, very severe one. He put on ECMO and then he cannot win off ECMO. So in the, I think 7 days, because in the 7 days, we routine to do angio. In that condition, in that time, we found there are some coronary artery obstruction in the left main. The reason we think it may be some debris in the left atrium when we do osmosis. There are some fat or debris drop into the left atrium, and he may pop out when the heart become too okay. It may be 不是，我现在怕我 ，Let me see， 这台大系统，对我用的是台大，我不要怕。我说我们台大系统没有说。我小是跳掉。对，台大系统好像这样，台湾大学系统好像这样。OK， 这样可以，我要进入。OK， 然后再去试试 Zoom。
Yes, we are late. Professor Chen losing the signal. We will need like a couple minutes. Thank you.
when we see there are some primary graft failure, when you encounter condition, usually you will recover in the second day or in the 3 days, especially for the stunning heart. So the patient, if there are some doubt, you will do the coronary angio immediately to rule out the coronary disease. It may due to the foreign body, it may due to some reason you don't quite understand. Okay?
Display here.
Okay, so we do the angio. There are no problem of the coronary angio. That's why we say, okay, the only thing we can do is just wait till the recovery or wait to the retransplantation. Usually, we don't like to retransplantation for the patient immediately after the first transplantation. We encountered one cases of the immediately retransplantation. It may be 30 years ago when I was arrested. My boss had a case. He is the professor of chemistry. He has coronary disease and he received the heart transplantation under the Tema support. But the patient received the heart transplantation, did not win off the ECMO. So my teacher, my boss, very anxiety. So the other heart comes out. He retransplant immediately. The patient received a very quick retransplantation. You will go to a so-called immune storm. The patient will deteriorate and suffer a very poor and complicated post-op care. So in that case, we learn one thing. If the patient has a primary failure, we just wait for a while, maybe for 1 week or 2 weeks. See whether the heart will goes out, or the heart continue to become much better. For this patient, he put on ECMO, and after that, day 4, he also under the ECMO support and a very high ECMO flow, and the latex become better, and the hemodynamic much more and more better, and except the left upper lung still have some hematoma. We check the position of whether it's a hematoma or lung congestion. You will see here, there are not so many hematoma. Most of them was congestion. So the reason why the patient has congestion, we also have some debate, and we check all pulmonary vein. It's all clear. We check the pulmonary artery whether they are kinking. Why I say this very special issue? When you see there's something wrong of primary graft failure, first of all, you must think, is there any anastomotic kinking, especially the pulmonary artery? Because the pulmonary artery is very soft. Outer, the pressure is high, so it's very, very difficult to get a kick, but not pulmonary artery. Sometimes there's something wrong. When you do osmosis, it's very quick, but you will see there's some kink over the pulmonary artery. We have some experience 20 years ago. So nowadays, I very carefully to do the pulmonary artery anastomosis, to do a stent suture and suture the pulmonary artery, and cut the pulmonary artery as short as possible. Because the longer pulmonary artery anastomosis, the higher possibility of kick when they start to beat. Okay, that's the Okay, and we also see there are some white out of the left lung. So we're thinking, okay, whether could it be possible there are some black clot of sputum impact over the bronchus? So we check the bronchus immediately, bronchoscope immediately, but there's only some sputum without any black clot or any lesion. So he kept the ECMO support continuously, and the lactate more and more stable. And the day 5, we try to sternal closure. And this is the immunosuppression we have as I know, this is our protocol. Even in the ECMO support, we still use the ITG. But most of the ITG may reduce size. And we also start our protocol with FK with prednisolone. And the day 5, we close the sternum, and the day 8 is still an ECMO support. We also received the myocardial biopsy again. Since if the patient under the ECMO support, and we may, after transplant, we may think which one he could be infection or rejection. The evidence of the rejection we can get from the myocardial biopsy. The infection or sepsis only suspect by the clinical judgment. So the only evidence we have is myocardial biopsy. So I do not hesitate to do any myocardial biopsy because we know every myocardial biopsy take 5 pieces or 6 pieces. They are sampling concept. Sometimes the sampling is wrong. So I'd rather like to perform more frequent the myocardial biopsy if the patient was unstable. Okay, we see the even in the ECMO support, the pressure is still high, but there are no severe or human rejection. So we can definitely show it just take care, just wait. The patient will be resolved after the condition. And he do the day 8, 9, he do an echo again. EF still poor, about 40, even under high ECMO support, 3.0 from floor. And this is the data, week 2 summary. The hemodynamic become more and more stable. The blood pressure become good, and the inotropic down from 12 down to the 3, and the ECMO flow down to 2.7 down to the 1.6. So it's a good time to remove the ECMO. About a good time, and the bilirubin drop to 7, it goes slow down. Okay, and then with in April 28, we decide and remove the ECMO under the inotropic 1.6 and the VA ECMO 1.3 liter, and we remove the ECMO about 2 weeks later. So don't worry about the poor condition. If you believe there are no coronary disease, there are no rejection, we just wait. Okay, and he can remove the ECMO smoothly. And the echo shows here, if you can see, the EF become better, approach the T. So it means the Marcus stunning is longer than we thought. Okay, this is the X-ray we have now, and from very poor one and become still poor. Okay, but the condition, the white count is become better, and the CRP become much better. Okay, there are some infections, sputum culture, so do some antibiotic treatment. So the time course, perform the second time biopsy under the Bosmin, low dose Bosmin inotropic 1.6, and also the peer pressure dropped down a little, but the wedge become better. If you remember, the wedge pressure in the first time biopsy is about 20, but the patient was under the ECMO support, the nearly high flow. But nowadays, he become much improved. The patient without any ECMO and the wedge become much better. There is no rejection, but you must very carefully about the biopsy data. You can see here, the PSA is not adequate specimen. So sometimes cardiology do some biopsy, maybe some penetration. So don't believe the one times or two times by themselves. If you have any doubt, just do it. And you will increase the experience of the cardiology to do the biopsy. Okay. So we also try to win after the winning of the ECMO. And he can win off the ventilator right now. And after that, the left lung still hesitant. So we do the CT show there are some blood clot. So we will evacuation the blood clot again. And something happened after the extubation. So you do the echo. Okay, and he had developed some sepsis after activation and under the norepinephrine and some dopamine. Okay, but the ejection fraction still dropped to the 40, and we try to figure out what's wrong, and it may be the infection. Okay, so and in that time, he dropped the LV function and become hemo unstable. The blood pressure drop. We may consider two things: one infection, one maybe rejection. So I give the sorbitol immediately for 3 days and do the biopsy again. As I said just now, the infection and the rejection, the only evidence we have is rejection. So I just do the biopsy, proof there's no cellular or human rejection. Once we prove this one, I will decrease our immunosuppression. I will decrease, so I will lowering the dose of sorbitol, lowering of steroid. We can give a huge dose, short-term sorbitol is fine for 3 days. You don't worry about the infection. But if you keep on the high dose of the steroid, you will go on the fungus infection. So once I prove there are no rejection, I just give the sorbitol 3 days. Then I will decrease the steroid. I will do a contrast CT. There are some blood clot over the left side. The contrast CT shows the same. Okay, so to reopen it, and now we start still to care the patient. He had some problem of the right growing problem of the ECMO wound. Okay, this is we have. There are some bilirubin rise up, and there are some infection source. Okay, this is what we have. So we go to the operation room because there are some blood clot here. We open a small wound here and put on some drainage for the patient, and the lung comes out. Okay, and the echo shows the EF much better, become to 40, and you extubation again, and the the less than biopsy also shows good condition. Okay, this is the data we have now from the EF from the 40 to 55 to 40, and the blood pressure, the PAP is more and more stable, and the stable times of the biopsy were no rejection, no cell rejection, no human rejection. Okay, so this is the case we encounter for the primary graft failure with recovery. Okay, let's talk about the general condition of the primary graft failure. Usually, the primary graft failure, it depends on usually in the past time, I say it include the left side and the right side. And for the left side, you can see the echo, they include the left side of biventricular failure. And the right side is the myocardial, left side is good, and right side is distended. You have sometimes we will debate about this is due to the pulmonary hypertension crisis or due to the poor RV protection. I think we always debate this kind of the condition, but nobody knows which one is the correct one. So they also say there may be some secondary graft failure. So I think this is only suspicious diagnosis. Okay, we can see as for the left side, you can see there's a mild graft failure or moderate graft failure. Usually, if the EF less than 40, we call mild. Okay, if you can see here, there's some definition from the journal say there one criteria. If the IP more than 50, weight more than 20 in the operation room, and one criteria for the following for the high dose over the 10 is so-called moderate. Usually in my hospital, we have lots of the this kind of moderate graft failure. So and another issue is, did you put swan-gum pulmonary catheter for any case under the heart transplantation? Yes, if possible. If possible, we'll put on the swan-gum. So put on the pulmonary catheter. But sometimes the patient is very critical, and we don't have time to put the pulmonary catheter for the patient. We just do the operation or transplantation only under the central venous line. Okay. For the sometimes we will see a severe primary failure. It means that you need IBP, you need the ECMO. It's good for IBP. So there are also see if you need new IBP, you may characterize the patient was a moderate primary graft failure. Okay, how about the right side graft failure? It means the IP over the 50, which let's say 50. For the condition in the operation room, sometimes it's very difficult to differentiate which one is right side. The cause of graft failure is left side or right side, unless the LV function is good, but RV is not so good. You may see it is the right side. Okay, so but if the patient more condition we have now is we use more marginal donor because there are some waiting list pressure. There are another topic talk about what's the marginal donor. For briefly, for marginal donor is old age, CPR, CO2 intoxication, suicide. It's clear time more than 24. You can see this marginal donor. But sometimes because the waiting this pressure. The pressure is not only from the patient, but also from the surgeon, because we have some pressure. If the patient condition become very poor, you have to put any possible heart to the patient, especially if the patient was under ECMO, the heart is very poor. You think any not good heart is better than the bad heart. So the condition we usually make is that condition. Okay, so maybe, and also because of the advance and the improvement of the ECMO support, more and more centers would like to use the ECMO support for the border zone myocardial. So, for example, nowadays I teach my colleague or my student outside my hospital, if there's something wrong, something dark, you can put on ECMO for the heart transplantation patient. And you only take 2 days, you can recover. Especially for the first night, we were struggling about the reopen or about the car cloning. Why not put on the ECMO and wait he will recover in 48 hours? So in the threshold for the ECMO support is decreased recently. So it may be overestimated the instance of the graft failure. Sometimes it may be, you don't need the ECMO, but you still would like to put on ECMO for the better survival. Okay? So talk about epidemiology. It's just a survey. So epidemiology say the graft failure about 14.4 and 17.4. Usually you can say about 10%. About 10%. So once the patient has primary graft failure, the 30-day mortality of 30, 1 year's mortality of 40, one third. You can see here the data sheet. The data shows here the recent data, the recent year, the results is much better. Much better. Okay. I usually talk about my patient. The transplantation immediate survival rate is 90% in 1 month, even he's good or bad. Usually the patient was functional 2 or status 2, the condition is good because it's a well salvation case. Usually the patient died was such as so complex case, so patient was under the bed or under the ECMO support. Okay, so and what's the pathology of the graft failure? As I just mentioned, there are some factors. One is donor factor. So some donor may have serious insult, such as brain death, such as hypothermia, ischemia during transplantation, such as the multi-organ procurement. The general surgeon will cut down the IVC, sometimes wrong, and you're bleeding a lot. It happened in my country. Okay, and sometimes one ischemia. Okay, so this is a donor factor. But also brain death, also a special physiological phenomenon, including the ICP, including the visceral tone issue. So that's why we will always talk about when we do the heart transplantation, we must care from the donor side. You must keep the good visceral tone. But when you care the donor, another point of view for the general condition, for the ICU doctor, they just use the norepinephrine because it's more easy to keep the good blood pressure, but it's not good for the heart, but also not good for the renal perfusion, right? So if you want to care, you must go to donor side, wait and see 2 or 3 days. If you see Dr. Joe in that time, in press time, he go to the ICU, go to the donor side, he take care of the patient for 2 days, then harvest organ back to my hospital. So donor care is another story. You must care. And usually, you must care of the muscle tone, and you also must take care of the lung condition if you want to take the lung organ. Okay. Also, sorry. Okay. There, for the graft preservation, there are two. 20 years ago, only one policy is hypothermia, ischemia. So the current suggestion is ischemia time. You have better less than 4 hours. 6 hours is fine, but usually we can say 4 hours. But nowadays, 10 years ago, we always hesitate. We hurry up to do the procedure as soon as we can. So in that condition, when we dissection the heart, you take a lot of bleeding in the rough service. So nowadays, we don't care about the ischemia time. Usually 6 hours is fine, because if the patient have this good dissection of the heart, you will decrease the post-operation bleeding. You will decrease a lot of the chance of the primary graft failure. So we would like to don't care about the ischemia time, but you must, there are some action you must choose is the size of the patient. What kind of cardiac pressure do you want? And we also have some debate. 20 years ago, we only used the cardiac pressure salt. Nowadays, we change to the HTK. Recently, in France or in United States, they may have the UW solution, Wisconsin solution, but it's not available in Taiwan. Okay. And the volume, also you must think. Okay. And the older donor also has a problem of the primary graft failure. So let's talk about older donor. It's been the LVH possibility of the chronic disease. This is so-called marginal donor. Marginal donor decision take or not to take is a debate issue. Not only for the surgeon and cardiology, because patient did not know. Actually, they did not know. Okay. Talk about the wall ischemia revision. There are some studies about the cyclosporine. I think I will skip this slide. Usually, intracardiac cardiac pressure implantation, warm cooling or hot cooling, but it's not so important. It's only for study. Okay, this one is a risk factor for graft failure. I talked before, maybe a donor factor, maybe a recipient factor, maybe the procedural factor. The better way to prevent is prevention. If there is something wrong about donor, you must think you may have a high instance of graft failure. You cannot choose donor. So donor age is still here. The paper say you must have a good donor, but 20 years old, 22 years old. But in my hospital, usually 40 or 50 years old donor we have. And gender mismatch, but you cannot choose. And the cause of death, actually, you cannot choose. If the patient has the CBA 60 years old, I just take. And the patient may have the coronary disease, you may take. And the patient with the inotropic requirement, it usually happen. I never see the patient without inotropic support. Usually about the 10 microgram dopamine or some norepinephrine. It's quite often. Okay, sometimes there's some EKG change. Okay, if possible, you can ask the donor hospital do the cancellation. In my hospital, at least, if we have some doubt at the EKG change in the EKG in the donor side, we will do the cancellation for the donor, but not every center do that procedure because not works, it's not reasonable. But for recipient, is reasonable. Okay, so the only things we can do is go on the operation room to prepare the heart. If the heart, there's some calcification, sometimes we will discard. If recipient side is very poor, we'll take. So also the risk factor of graft failure also depend on the recipient factor, including patient have the problem of the occurrence support before, have the age, have the end sternotomy, have amyotrophy very poor condition. And also they have some procedural factor, including the ischemia time, bypass time, seismic match. Okay, is the recommendation here. So the AV procedure will lead to the possible primary graft failure. Some factor you cannot change. We just say, okay, I know here primary graft failure. We just try our best. Okay. Let me see. Okay, this is the study. Could we justify which one is more high risky? Yes, there are some studies. This is 2011 Journal Harlan. So there's 6 factors for recipient. IP is high, H is tau, BM is a very simple one, and the donor age more than 30. For that condition, they say, I think this is older data. The donor usually in my hospital, I think only 10% less than 30 years old. Usually 40 to 50. It's care time, usually over to 40. Okay. Anyway, he said, actual survival, if there are some 6 factors, the primary graft failure instance 1/3. If the 0, primary graft failure was 2.9. Okay. So you can prove, it's fine. Or validation data show it's correct. So this is only a simple score. If you have this problem, you may say, okay, you will have a high risk. Don't worry about it, just do it. Okay. This paper talk about the etiology, why they have the high risk of a severe graft failure, and maybe due to they use the ARB, you have one product, they are scoring, and it's a kind of study. It's from the study, and I think this data is from because this is a UCLA leader, Kabashiaki. Okay, so this may be some biomarker you can check once to the troponin I, BMP, etc. Okay, so how to prevention of graft failure? So you must do the donor management, better matching. Maybe in the future we may have the warm ischemia preservation, such as the organ care system, and how to prevention and gradually winning on neutropy, using the nitric oxide to decrease the possibility of the pulmonary hypertension, and decrease of the ischemia time, decrease of the transfusion, and improve the procurement technique. Okay, and the selection. As I say, just as I said before, donor factor, recipient factor, procedure factor. Okay. Organ care system is a warm care system. It proves its work, but the problem is this standard cold storage group is now very standardized. Under this one, we must have some extra solution And in some country, it's not paid by patient itself. So it takes a lot of money. As I remember, about 30,000 US dollar for each patient. So, but only for the borderline heart. So, in that condition, at least in my country, there are some ethical issues. Because once the recipient pay for the money for the solution, they will misunderstand. They pay for the money for heart. So it will become very, very big issue.
Yeah.
So I hesitate to advocate this kind of the machine unless the payments by the government or by the hospital. But the hospital usually did not take because it's too expensive. But for government, it's also too expensive. So we suspend there. Okay. How to measure the paragraph SI? The case you show, we always present the method. We use the catecholamine, we use the IVP method representation. I hesitated to advocate immediately. As I say, okay, use the NO with the Bosman. For the heart transplantation, we have some data shows VECMO may be the better solution than the bed. Because bed, you take a lot of time. ECMO, you can do immediately, and then you can wait 2 weeks and see what happened. If the heart did not recover in the 2 weeks, you may consider go on the and put him to the retransplant list. So just wait a minute. Okay, we also can use the level sedating. This is called calcium stabilizer. Not available in my hospital. I know he's available in some hospital in Taiwan. I don't know whether in Indonesia. Because in my hospital, my pharmacy say things is similar to the dobutamine. So they're allowed to import to my hospital. Okay. So I think it's fine. Sometimes you can. This is a study for the plasma phoresis. If the patient has some problem of the rejection after the transplantation, it's maybe called the primary graft failure. It's not the immediate primary graft failure, but sometimes it's the secondary, and the days later or weeks later or a month later, or we can use because of the rejection. We have to do the plasma change and the plasma phoresis. Okay, so it's also talk about the how to management. So when to use ECMO and the outcome. I think outcome is acceptable. When to use is early recognition and diagnosis. Even I would suggest a little over estimate. It's okay. If you have a good hemostasis and if you have the relative high inotropy, just put on ECMO and wait. And sometimes just from the sternum, do not from the groin, because when the patient, sometimes you will use a very high inotropic. There's something problem of the distal perfusion. You just from the sternum. It's easy for a surgeon to take out or to go to operation to remove the ECMO, more easy. Okay, timing. So improve the timing. Bed or ECMO for that, usually we will even the mortality are similar, but for the breathing, for renal failure, it's more easy. Okay, and you may from the sternum or from the common fever, it's fine. We can usually we are protamine for four dose, reverse in the operation room immediately, even under ECMO support. And because after the transplantation, you are breathing, So we just pack it and then wait. And tell the surgeon, go in if you have some doubt, a special component. And if you have time, go to operation theater. You just do the blood evacuation in the ICU. Just take out blood clot, you'll recover because the heart is good. Okay, the timing early is much better. This is the late ECMO. This is a prompt ECMO. This is so there are some difference. Even the static is not significant. Okay, that is the paragraph. We must talk about the reentry. I think as I have now. Okay, thank you.
Thank you very much, Professor Chen, for your excellent presentation. We are so honored to have you this evening. I would like to invite all the professor, my senior colleagues, and all the doctors and nurses and all healthcare staff that joined this webinar to have a discussion with Professor Chen. So if you have any questions, or you can type on the chat box, or you can also turn on your camera and directly have discussion with Professor Chen. Oh, Dr. Dickey has raised his hand. Dr. Dickey, you are pleased to deliver your question.
Thank you very much, Professor Chen.
Hi.
Dr. Dian, can you hear me?
Yeah,
Yes.
we can hear you.
Okay, I'd like to know about how to improve pro-recruitment technique mentioned from your slide. Is it about the during operation or before surgery?
Mm-hmm.
What do you mean with the improved recruitment technique?
Oh. I think I don't know, because the procurement procedure is performed by my resident. 20 years ago, I performed by staff, but nowadays we perform by resident. So resident is sometimes under training, and I think not familiar. So we must take care to not perform too many dissections. Okay. Just brief cross count and remember venting, because when you give the cardiac pressure, the LV will distend. So remember to venting the left side, either from the pulmonary artery or the LAA or the right pulmonary vein.
Oh, you mentioned about the technique, how to harvest the donor heart.
Right, procurement.
Thank you.
Thank you very much, Dr. Dickey. Is there any other question? Professor Chen is one of best cardiac surgeon here. He performed a lot of heart transplant surgery in pediatric and adult heart transplant surgery. So he had a lot of he had an immense experience related to heart transplant. Practically care by him also. Professor Chen, you usually sometimes use like marginal PVR for the recipient. Do you have any consideration, like put the patients into LVAP before receive the heart, because we just want to reduce the wedge pressure of left atrial?
Usually for the borderline pulmonary vascular resistance, such as between 5 or to 6, over 6, we will consider he may be contraindicated. But for the adult patient, usually if the patient have the PVR, at the first time he do the consideration over 6, I will routine to perform, give the patient with the inotropic drip. Then about 1 or 2 days under the 10 microgram per kilo per minute dopamine or dobutamine and do the catheter again, usually you will decrease less than 6. Okay? Okay. If the patient have the borderline pulmonary muscular between the 5, usually we will pick a bigger heart, more bigger heart. And if we don't have the bigger heart, I will say, okay, we will do the transplantation, but we must prepare the ECMO because I can expect they were struggling after the transplantation in the ICU. So why not put on ECMO in advance? You're more easy. I'll get a good sleep and just wait 2 or 3 days. The pulmonary muscular will drop. So another issue is the patient is the high PVR, relatively high, not so high. And we already put on the bed. How long we should wait for the heart transplantation? Usually we recommend for the durable heart is 9 months later. 1 month, it may be too early to transplant because of the adhesion, because of the procedure, immune activation. So usually 3 months later to between 3 months to 9 months is the best time option for the durable bed. This is data, I think it's data from the IHLT. For the temporary bed, we usually perform the transplantation if possible, as soon as possible, since there are some different stories. In temporary bed, the patient cannot discharge, so you will occupy the hospital bed. For the durable bed, it's not easy. But another issue is for the durable bed, for the patient with durable bed, they also would like to pick or choose a better heart. This is some kind of the psychological gain. You take him, you play the psychological game with the patient.
Maybe is there any other questions related to the general consideration of heart transplant? Since we don't have we don't really familiar with LVAD because we maybe just once perform the LVAD thing.
Wait. Oh, okay.
So we are not the center who have who very familiar with mechanical supporting, especially pre-operatively. So do you have any suggestion for our center to build the system of heart transplant and pick the right recipient?
I think first of all, for the heart transplant program, you had better have the LV program, LVAD. You don't need initially use the durable bed because it's expensive. We started our temporary bed, I think 20 or 30 years ago. The device we have is biopump. We use a biopump only. And nowadays, if you have the ECMO pump, such as rotaflow or cardiac help, you can use because central okay. In my hospital, in my country, we consider central as a temporary bed. We also consider cardiac help as a temporary bed. So it's quite different strategy. Our reimbursement policy say we consider the cardiac help is the temporary bed, not only the ECMO. So because the pump is good, the only thing is you give some oxygenation in the oxygenator. So sometimes we will come the the agitator. So it can also work as the temporary bed. Usually, that condition we can use about 3 months or 4 to 6 months. So now, since you have the cardiac help, so I think you can start your LB program. And if you have central you can cut out the cardiac help, use the central
Cardiac help.
Use cardiac help first as an LB. Then the patient was improved without oxygenation. You can clamp the O2 supply, and it becomes a simple one as the cardiac help, as an LVAD, temporary LVAD. And if you do not like the oxygenation, just cut it off. Just pump. Use the centrifuge. So the patient will survive, and you have more and more chance to do the heart transplantation, because for this group of patients, they will agree to receive the heart transplantation. It's a very tricky.
Okay.
If the patient has good condition, they say, why I need transplantation? I only have an inotropic drip. I want this one.
Okay. They want to
stay here.
Maximal therapy before
usually they want to stay here because they are no harmful. But once they are put on bed, they put on the ECMO, they will say, yes, for everything. They will say, yes, for everything.
Okay, is there any other question related to our topic, mostly about the postoperative, since the primary pulmonary dysfunction or failure is one of the worst scenario that can increase the mortality rate for transplant surgery? Maybe is there any other questions from the professor, colleagues, and doctor, or any other healthcare who will join this webinar?
Hello.
Yeah, Dr. Eva, thank you for joining us. You're pleased to.
Hi, Dr. Yi. I know you very well from AP also.
Hi.
Nice meet. Yeah, nice meeting you. I'm just asking, maybe you're from the adult side, adult service, but we are here from a children's side, yeah?
Okay.
Children, baby. From National Taiwan University Hospital, how is your experience for the cardiac transplant for babies and children? And I don't know, when I was there, I saw your patients, like baby and adult, baby and children, but it's a lot of adults get ECMO, but I don't see that you have a lot of children for ECMO. Why the service is a lot, tend to do more for adult instead of children? I'm just asking, and just a very quick questions.
The definition of children, I think you are talking about the less than 10 years old, right? We have pediatric transplantation less than 5 years old, maybe only have 10 cases, because we seldom have the donor less than 6 months, and we occasionally have the donor around 5 years to 10 years old. It's because of the shorter donor shortage. And we have some pediatric ECMO. Usually is for the post-op care, such as the arterial switch, such as the complex congenital heart, such congenital heart, and such as the ECPR after the cardiac surgery. As I have some data. We about have the 50 cases a year of the pediatric ECMO. 50 cases a year, and we have less cases of the ARDS in pediatric group. The ECMO we have more and more in pediatric group is VA ECMO for the post-op care. Okay. And we also have some data, published data, I think before, 10 years ago, talk about the pediatric ECPR. There are well selection cases, and most of them can survive, I think, about 50%. 150%. And for adults, only 20 to 30%. Because for the pediatric group, they usually collapse in the ICU. So for the post-op status, we will rather like to put on the ECMO, even if there is something problem.
Dr. Eva, you're still muted.
Sorry. So how many cases for adult ECMO in your hospital? If you said it's children 50, and how many is it for adult?
150.
150. So three times that.
Yeah.
Why you like to do ECMO in adult instead of children? That's my question.
But
why is it 3 times? Because here in our hospital, we love to do ECMO for children more than adult. Because
actually,
the survival rate is better in children.
Okay, I only say we seldom use the ECMO for the ARDS in pediatric. They will try everything unless they are collapsed. But in nowadays, the chest care or the chest surgery, the chest care in pediatric group, since they are much better than before. And I know in other countries or in United States, the PPHN, such as the neonatal one, they would like to put on ECMO. But as far as I remember, we only put on the PPHN for neonatal in 10 years, about 5 or 7 cases only. Very, very few. Very, very few.
Okay, thank you.
Thank you.
Thank you, Professor Lee. Nice meeting you.
That's it.
Okay. Is there any other questions or comments for this webinar? Maybe the phone.
Okay.
Okay. I think if there's no other question, we can close this webinar. Before we close, I would like to conclude today's webinar. So pulmonary graft failure is one of the worst scenario of heart transplant surgery. So the most important thing is to prevent. It is included the donor side, recipient side, and procedural side. And the third conclusion is we have to be prepared for mechanical support as soon as possible as we suspected the pulmonary graft dysfunction. It's better if we overestimate it before we figure it out what will happen after the heart transplant surgery. Thank you very much to all professors, doctor and colleague, nurses, and all healthcare joined this webinar, and also Ms. Jane, Dr. Mira, Professor Ben. Thank you very much. We're very pleased to have you today. See you on the next webinar.
Thank you.
Thank you very much.
Thank you.
Thank you very much.
Thank you.